Certainly, Yafell, if you want to chime in, we'll try to there he is. Dr. Ellis, you see Dr. Ellis there in the white coat. He's one of my partners. Neurosurgeon Yafell is an interventional neuroradiologist. Rafael Ortiz is my partner in crime for many years. We've been working together on Moya patients and in general neurovascular disorders since the early thousands. And my name's Dave Langer, and I'm the chairman of the Department of Neurosurgery at Lenox Hill. I think the reason for doing this, number one, it's a great opportunity to educate both ourselves and meet Dean. We met on social media, actually, and in celebration, if you want to call it that, of MoyaMoya, World MoyaMoya Day. Obviously, with COVID, there are issues that have come up related to COVID and related to MoyaMoya. And I'm sure people who either have had the disease or have had surgery or haven't had treatment or know people who have had treatment, the questions of how to behave both from a medical perspective and a patient perspective has come up given the strain that's been on hospitals and on decision making. So be that as it may, I thought that this would be a good opportunity to introduce our team to the MoyaMoya audience and the Dean in particular, and then go from there to discuss what's happening in the hospitals, number one. Number two, how does that impact all of our patients? And then three, how we're going to move forward and what should you do if you have Moya disease now? And we can talk about decision making. I see there's one chat person that says they can't hear. I don't know, Flora, if you can message that person of how to do that. Would be Josh Pelletier is saying he can't hear. Probably it's on the computer side because I can hear Dean and he can hear me. So there's probably something on your computer, either the volume or your controls. So, or your mute button is, well, that wouldn't work there. But anyway, Flora, if you could reach out to them through text, yeah, that'd be great. So I'll start off with Dean. Dean, I think you had some specific questions. We could start off with your questions and go from there.
Yeah, I think one of the biggest questions that I've heard, is, here I am, someone's got a patient that has got MoyaMoya, and their big concern is, am I at any more risk with coronavirus than anybody else out there who's could be susceptible to getting the virus? Is because I have MoyaMoya disease, am I at any greater risk? We've heard some things about some younger folks having stroke symptoms or actually having strokes as a result of this disease, or of this virus. So I was curious as to how you would address that. What have you seen? What have you heard, being that you're at ground zero in New York?
Guys, why don't Yafell, we'll start with you.
Hi, everyone. So I think that we're understanding more and more the disease as we have seen a lot of these COVID patients, and there seems to be a correlation between how prone COVID patients are to have hypercoagulability issues. So I think that given that, of course, MoyaMoya patients, in the case of specifically of MoyaMoya, rely very heavily on good blood flow into their brain, it is fair to say that they are more prone, very likely, if they have COVID, to develop ischemic events. And in fact, we have seen already in the last couple of weeks in Lenox Hill, a couple of examples where we have seen patients with MoyaMoya type disease who have come to us with ischemic events, and unfortunately we have successfully treated. But I think there's definitely some potential correlation between COVID and the symptoms in COVID and precipitation of symptoms in these MoyaMoya type of patients.
Jay?
Yeah, I would sort of echo that. To take a step back, though, I don't think that if you have MoyaMoya, you're more likely to contract COVID. Mm-hmm. But if you happen to have COVID and MoyaMoya, I think you can definitely see a precipitation of some of the ischemic symptoms because, as Dr. Serulle said, you're in a hypercoagulable state. And as we know, before we get to surgery, we often medically manage MoyaMoya patients, typically with blood thinning medications or antiplatelet medications such as aspirin and Plavix. And those medicines really don't work as well if your body is also fighting the COVID virus. And so I would say that certainly the MoyaMoya population of patients should try extra hard to not contract this virus, because it does put them in a more compromised position.
Prof?
I agree with what has been mentioned until now. And we need to add that regardless of what's happening with COVID these days, if someone has MoyaMoya, they need to address their issues, their clinical issues. They need to have the workup that anyone with MoyaMoya would require to determine if they are at higher risk of having a stroke. The reason why MoyaMoya can become problematic is because of the risk of stroke, whether it's hemorrhagic or whether it is ischemic, of blockage of an artery or rupture of an artery. And we need to determine who is at higher risk of developing stroke or stroke symptoms due to MoyaMoya to then assess if that person should be treated to prevent the stroke. And treatment, I'm talking specifically about doing a procedure, a bypass, revascularization surgery, which we'll talk about more later in this hour. But if someone has known MoyaMoya and they're having symptoms of mini strokes or TIAs, or if they're having any type of stroke symptom, they need to be attended. They need emergency management. They need to call their surgeon if they already have someone that is taking care of them. And if they don't, they need to go to the emergency room to prevent a major devastating injury to the brain. Again, we can prevent many of the devastating strokes if a procedure is performed before that happens.
Yeah, I mean, I think I told Dean earlier, I think before March 14th, we were in what I'd call a medical legal world. And now after COVID hit, we're in a COVID world. And what that means is, I'm not worried about lawyers, but in general, surgeons made decisions based on symptoms and severity of disease. And there's a bell-shaped curve. I mean, at least at Lenox Hill, we aren't treating asymptomatic patients in general. But if people have mild symptoms or just minimal symptoms, we often would, more or less leave it up to the patient to make a decision as to whether to have a treatment. We might push them to do it earlier if they had more severe symptoms, or if their testing suggested that they had more of a severe form. But in general, it was the patient's choice. And then we would basically say, you can wait if you want, but I would suggest that. And in general, what we don't want to happen is, as surgeons, you don't want to say you don't need this, wait, and then God forbid the patient has a stroke, because then it's really our responsibility to avoid that. We're helping you as patients make that decision. After COVID, I think what we're doing is we have to use the same paradigm. However, we have to also consider what the risk is of COVID as its own entity. And frankly, especially now, it's a treatable disease. We're really learning about it. And the biggest fear, and we're seeing this with many diseases, is patients waiting too long. That the fear of COVID in many ways is more dangerous than the disease itself. And obviously no one's reporting this. It's in the press. Obviously you hear of all the terrible things that are happening. And trust me, the month of March and April was one of the most, interesting experiences of my medical career. So it was happening. But the vast majority of people, if not the super majority, actually recover and do well. And we have better therapeutics now. We know how to treat people better. The caveat is, if you have symptoms, get treated, because the risk of having a stroke, if you're basically crescendoing with your symptoms, is much higher than the risk of doing poorly from COVID if you're not infected. And I think, to Jason and the group's point, if you have COVID and you're a Moya patient, you probably do have a higher risk of an issue. And so we would probably defer on treating you as long as we can. But if COVID, God forbid, accelerated your symptoms, I think we would be forced to treat you. And that goes true of any of our neurosurgical emergencies. The only patients we're treating right now are people that have impending neurological deficit or are presenting with a neurological deficit. And so we have to be aggressive when we have to be aggressive, and we have to be conservative. We can be conservative, and that's COVID or no COVID. So I think from my perspective, that's kind of the way I certainly think about it.
Yeah, a lot of the patients out there that, you know, have MoyaMoya, who may have been through at least a surgery or possibly two, know that, you know, they want to stay away from COVID. And, you know, it's just, I think it's anybody who's got any type of a rare disease knows that they're probably at more risk. Are there things that they could be doing, you know, to give themselves additional protection? You know, the social distancing is one thing. You know we want to stay away from any crowds or anything like that. But, you know, I know the biggest thing I hear about for the patients is, you know, hydration. Make sure you don't get dehydrated. Is there any other advice that you would give MoyaMoya patients who are in a maintenance mode in trying to stay protected from COVID?
Raf?
You said it yourself, hydration, number one, making sure that they take the necessary precautions so that they decrease as much as possible the risk of infection. If they're taking antiplatelets, if they're indicated, meaning aspirin or other medications, they need to stick to it and be rigorous with the regimen. But that's it in terms of preventive measures. And again, I need to keep saying it. If someone with known MoyaMoya is having symptoms, that has to be addressed urgently or sometimes emergently more than the COVID situation that we're dealing with right now.
Jay?
Yeah, I actually have a patient that I'm working with right now who was diagnosed with MoyaMoya in late February. And we had scheduled her surgery for mid-March. And unfortunately, we had to delay her surgery because, you know, things really came together at the peak of the COVID crisis. But I had to figure out ways to sort of optimize her and allow her to remain healthy until we can reschedule her surgery, which technically is elective, but she is, I would consider her at relatively high risk for another stroke, and she's had at least 2 or 3 strokes already. And so, you know, I worked with her stroke neurologist, and we added, we increased the dose of her cholesterol medication. We actually added a second antiplatelet agent. And, you know, these were things that are temporizing, but I think it's important to remain or further optimize the medical regimen that you're on if for some reason surgery has to be delayed.
Anything, Yafell?
No, I fully agree with that. And just to reiterate the fact that we have to be mindful of COVID, but, you know, as both Dr. Ellis and Ortiz said, I think it's very important that if a patient is having symptoms, you know, I wouldn't delay by any means seeing or trying to approach a physician or their physician during this time. We have made ourselves available through telehealth, and I think many others are. So when a patient wants to see one of our doctors, we are readily available to see by video conference. And, you know, there are ways to do this right now. So I think that making ourselves available for the patients can at least, ameliorate the fear for being exposed, you know, to COVID by going to the hospital.
So something that Jason mentioned that I think is very, very important. He mentioned the stroke or vascular neurologist, and when I say what I say is very important is the team approach. Whenever someone has a complex cerebrovascular problem, there is a need for a real team, multiple individuals working together with different expertise. And an example in our institution, you're seeing 4 of us here, but there's many more people that work in patients that have MoyaMoya. And we have weekly conferences in which we discuss the workup options, the management options, medication, surgery, and timing of those interventions. And when I'm talking about from the radiology side, we have experts in neuroradiology that work, yes, like reading MRIs and reading CAT scans, but also expert in radiology, on the radiology side, an expert in nuclear medicine that has a background, that individual has a background in clinical medicine because he was an internist before becoming a radiologist. So he understands the physiology of whatever he's looking at and trying to interpret on the images. Then you have the stroke neurologist. You have so many people with MoyaMoya have seizures. So we have the epileptologists that we work with. Then you have the person that does the endovascular procedures, the angiograms, which are the diagnostic procedures for more accuracy at the time of testing or evaluating someone with MoyaMoya. And then you have the neurosurgeon that is going to perform cerebral bypass surgery if necessary, the rehabilitation portion, and nurse practitioners, physician assistants, the ICU care. So it's an entire team approach. And it's going to be critical that in these days, whenever someone is trying to make a decision of timing, of right thing to do, that the team that is taking care of them has all these resources in order to be protected as much as possible.
Yeah, I think the only other thing I would add, I think that was very well said, was that the key to avoiding COVID is doing the things everybody else is doing, number one. Number two, it's, there are some, and a little secret, there are a few little things that have come up. There's a drug called Pepcid or famotidine. This may be protective or at least an early treatment. So I don't think it'd be crazy, especially if you already know you're minimally symptomatic or you know you have Moya and you're not having surgery. And the Yafell's point is that people who may be even minimally symptomatic or asymptomatic, if you got COVID, that could push you over the edge because if you got hypercoagulable, so that's a kind of a different problem. It's like you're not going to need surgery if you're not having symptoms. It's just incidental, and if it worked up and you don't have a demand. So what can I do? Because if you do get hypercoagulable from the virus, that could make you more susceptible to developing a stroke. And so what can you do? Well, take your medicine, stay hydrated, but also Pepcid may be beneficial. It's a safe drug. I've told my high-risk family members to take it. I'm not taking it personally. I will, if I got a fever and cough, I would take it, to be honest. Only because for 2 reasons. One, we know it's safe. It's got a good safety profile, and there's good data that scientifically this may work against the virus and avoid viral infection and viral shedding. So to me, there's no reason not to take it. It's either going to be, as they say, you either have expensive urine or you avoid having COVID. So, it's as good as any homeopathic medication you buy at GNC, and we know it's safe. So that's one thing that probably will come out in the next few months, our data. We're running a trial looking at famotidine, and I think there's good data that shows that people who are on it do better. So I think that's something that I would probably consider doing.
Should we log off and run to the pharmacy now to buy it?
Sure, go for it. I already did. Amazon, the price of famotidine has already gone way up. I'm not the only one talking about this stuff. But by the same token, I think that the other point that was made is, I know one of my patients is on this chat. When you're not symptomatic, you don't need surgery. We don't operate on people who don't have symptoms, no matter what the scans show. So that's not true everywhere, by the way. We will not operate on you if you only have a headache.
Yeah.
However, if you have blood flow testing and you have angiograms and NOVA testing, which is our quantitative MRA that show you're at risk, and you're having stroke-like symptoms, we're going to recommend surgery or treatment, I should say. And the truth is that it can change. We had I recently treated a woman who had very little symptoms a year ago, started developing crescendo symptoms, kind of like Jason's patient, and it was right in the middle of COVID in March. Well, that's not the right time to bring people in, but we're at a different stage of COVID right now. Half our hospital's empty, and it doesn't mean there's still not COVID patients around, but the bottom line is the risk of you coming to the hospital and getting COVID and then dying from some COVID-related illness is infinitesimally low. It doesn't mean it's zero, but it's much more risky if you're developing stroke symptoms, if you're having a stroke. So that's the real risk. Yes, there's probably some small risk if you're developing COVID, but we're working in the hospital every day. You know, we're no different than you are. Yeah. We're taking precautions. We're wearing a mask when we wear a mask. We're washing our hands. We're working in COVID units, but we're not getting sick. And I know I've never had it because I got antibody testing. My antibodies are negative. So it's not like had it and got over it. So I think, to me, we've learned a lot about the disease. We're comfortable treating patients when they need it. I would tell you this: we're not doing elective surgery. You know, we're not going to operate on somebody who doesn't need it right away. But in general, with Moya, you know, you're either black or you're white. Either you don't need it or you do. Yep. And to try to cut, you know, there is this middle group perhaps that has minimal symptoms or mild symptoms, and you're sort of worrying about and thinking about it. You're not sure if you want to do it. If you're one of those patients, I would wait. However, if you're having a symptom that we know is an ischemic equivalent, meaning a TIA type symptom that looks like and walks and talks and looks like a stroke, and your blood flow testing and all our testing shows that you have a hemisphere at risk, we're going to recommend surgery or treatment. And we would be it's very safe to go ahead and do it, and far safer to have the treatment now than wait till this all goes away. Because I have news for you, this isn't going away. Yeah. And it's not going away so quickly. And so we may not reach a point where it's totally safe for maybe even a couple of years based on vaccines. And I just saw something today, you know, the vaccines are being designed for what's called the surface protein, the S1 protein. There's some new reports that this is mutating potentially. If the vaccines are designed for the protein that existed 2 months ago and that protein changes, the vaccine ain't going to work. And so we don't know what's going to happen. We're very hopeful, and we're all cheering for our scientists and our medical people to come up with vaccines and be creative. But the answer lies in our ability to treat this with the current therapeutics that we have, and whether it's remdesivir or some of the HIV medications, whether it's going to be famotidine, whether it's just going to be steroids. You know, there are definitely treatments, and the risk profile for this virus in young, healthy people is still quite low. So I think that I would be very careful, and you have to trust your physician, and you have to trust that they're giving you good advice and that they're motivated for the right reasons. And I think that's the way to help you make your decision.
Yeah, well, one of the doctors earlier mentioned that, you know, this can be treated, you know, the MoyaMoya surgeries can be treated as an elective type of surgery. You know, if you've had some stroke symptoms, they may not operate on you right away. They may want you to get better so that you're healthy or healthier so that they can do the surgery. That's kind of what happened in my situation with my daughter. She had the stroke, and then it was a month and a half later where she actually had the surgery, so it was treated like an elective. The question I would have is, you know, right now, are those still considered elective? Or, you know, because at the time she was at a high risk and needs the surgery, needs the corrective surgery. So we're starting to see or hear people talking about opening things up. Is this process something that people can elect to have right now, or is it considered elective and we're avoiding them?
Rafa?
Well, this is definitely not considered the typical elective surgery. When we're talking about cerebrovascular disease, everything that we treat with a procedure, with a surgery, is to prevent a stroke. Yeah. Whether it's going to be a ischemic stroke or from blockage of an artery or hemorrhagic stroke. So this is not the typical elective procedure like for a knee pain or something cosmetic. The having said that, the most important is going to be the entire workup. Is that person having symptoms, number one, yes or no? Has that person had a stroke, a recent stroke, something new that we can see on an MRI, a recent MRI, that there was a recent stroke? Let's say they had an MRI from last year and they have one from 2 weeks ago and there's a new stroke there. Do they have low flow on this test that David mentioned before, the MRA NOVA, which is a quantitative MRA that measures the amount of blood flow into each of the arteries in the brain? Do they have that side of the brain at risk of having a stroke demonstrated on a nuclear medicine test? In our hospital, Lenox Hill, we perform brain SPECT scans with and without Diamox challenge to really assess if that side of the brain is at risk of having a major devastating stroke. And then doing the angiogram. That's the entire workup that we perform. Doing the angiogram to look at the blockage of the arteries as well as to look at the potential donors for a bypass. After completing that workup, if the answer to those questions of each of those tests is yes, there's a symptom, there's a stroke, there is a low flow, there is a territorial risk on the SPECT, then that surgery is indicated and it would be an urgent surgery. Maybe 3 weeks ago, when the hospital was filled with very sick people from COVID, and you had 100 people on ventilators, that wasn't an indicated time, but today, that person would, yes, undergo surgery.
Mm-hmm. Good.
Yes, and to follow up on that the patient I mentioned, we are ready to bring her in for surgery at this point. As Dr. Langer mentioned, the chances of her contracting COVID at this point is infinitesimally small, and we are getting things in order to bring her in for her definitive surgery. One of the issues that we're finding is that although we're ready to bring these semi-urgent or semi-elective cases in, the process of getting them into the hospital is somewhat complex. Mm-hmm. The timing of preoperative COVID testing has been variable and is still under consideration by hospital administration. The ability to get routine preoperative labs has been to some degree a challenge because many lab test centers are not open. And in fact, getting even medical clearance has been an issue because many primary care doctors are not yet open. And so it's a complicated process even once you've decided that it's time to have surgery.
Yafell?
Yes, just to echo that, at this point, we're on our next phase to start bringing patients back to the hospital. You know, you can imagine that right when COVID hit at its peak or before, as it was becoming more and more severe, the epidemic, we had to cancel a lot of our elective procedures. But now we're definitely in a different stage. I think we saw our peak probably about 3 weeks ago, 3 to 4 weeks ago. And now as we are approaching that next phase where we are calling patients. And yes, I'm trying to call a lot of my patients myself, obviously. And there's always a common thing that comes up in that conversation. Every patient is very afraid to come to the hospital. And we are definitely trying to take every precaution, not only to protect the patient, but also to protect ourselves and to protect the staff, to protect our nurses, our PAs who are working with us. So we have developed a pretty stringent process to you know, before we bring any patient to the hospital, we have developed a pretty stringent pre-screening process that includes, of course, COVID testing, among other things. So I think we're definitely in the next phase, and we're taking every necessary step possible that we can take to do everything that we will do to do it safely.
I think we can we all agree about that it's okay to come to the hospital now, basically. And I think New York City in particular, we were all worried that, oh my God, the sky is falling, and that this was going to be a terrible. The truth is, it's probably the safest place over the next year to have treatment because we've got the most experience with disease. I think we understand how to partition the hospital, how to wear PPE. We're comfortable with it. You know, it's like when I was a resident, it was HIV was around. This is going to change the way we protect ourselves. And HIV resulted in all the, you know, precautions now that we take with needles, for example, and double gloving. COVID's going to do the same thing for the foreseeable future. Mm-hmm. And I think going to one of the questions the audience has about D-dimer, you know, there are serum indices to look for COVID. There are really 4. CRP, D-dimer, ferritin are the 3 that we're using the most. And then procal, which is a indicator of infection, usually is used a little bit later. But obviously, if you have a MoYA patient that say didn't have symptoms, I'd say we probably would, if there was any indication, it'd be worthwhile to checking serum indices just to see, hey, just make sure you don't have some underlying asymptomatic infection, because the D-dimer is a relative risk of increased hypercoagulable state. So if somebody had a high D-dimer, I think I would probably wait, to be honest, unless they became more actively symptomatic, as opposed to thinking that's an aggressive reason to go treat, because what we do know is people who are operated on who have COVID don't do as well. And so we treat them if they are COVID negative. If a MoYA patient came in that had high serum indices and a negative COVID test, I probably would still wait, because there is a fair number of false negatives in the testing. And so if I'm seeing a patient that smells like COVID, we're going to hold off. Mm-hmm. For the same reason that we might hold off and, you know, if on a relatively mildly symptomatic patient to begin with, we want to choose that right time to do it. Now, again, if symptoms begin crescendo, I might change my tune, but we're dealing in a very unique time, and we're learning about the disease, and we have to, as doctors, we have to make decisions based on what we think is, you know, the best for the patient. And so we may not be perfect, but that's the way we're going to behave. The next question was about genetic testing. Really, genetically, the gene is on a specific, for MoYA is on a specific gene. It does run in families. It can. The trouble is that the vast majority of American MoyaMoya disease, or we call North American MoYA disease, is probably not the familial type. It tends to be more unilateral. It's more common in Black and Hispanic women. It may be more ischemic or atherosclerotic type. The Asian variant of MoYA, which is where it really came from, is a different disease. It presents similarly, and that's probably the one that has the genetic susceptibility and can run in families. But my feeling is that what we see in America, the majority is not the same as the Asian variant. And if you're a male who's 65 years old with MoYA disease, you probably don't have MoyaMoya disease. You probably have, we call MoyaMoya syndrome. And so I think that's more probably related to other genetic factors that are unrelated to the MoYA gene. You know, just the cardiovascular risk factors are the ones that are really most related. In fact, if I see a male who's over 60 who presents with MoYA, I really worry that something else, that it's probably more related to their cholesterol or their hypertension or their smoking or a combination of all 3. And as far as the last question about Pepcid AC.
Let me add something there, David.
Yeah, go ahead.
Even in the Asian variant, only 10% of the cases are the genetically transmitted, and it's an autosomal recessive trait, but it's only 10% of the cases in the Asian variant. So it's very rare that it would be something familial or genetic.
Yeah, I mean, I think the majority of patients we see are not a familial MoYA in general, especially in the United States. So I would agree with that.
Now you can see secondary MoYA in sickle cell disease, neurofibromatosis, other conditions that are genetically transmitted. That it is, but again, it's a secondary MoYA. It's not what we're typically see.
Does the microphones work for the group or just for us, Flora?
For us.
Okay, because one of the guys has a question. I think you have to type the question in because I don't think your mic. We basically got Zoom bombed on a couple of these early on by wonderful.
I can allow him to speak.
What's that? You can? Okay, why don't you, if you can open him up, he says he has a question. As far as the Pepcid goes, it's definitely something that's worth taking if you feel like it. There's no huge downside. If it's a past aneurysm patient who are COVID negative, same issue. I mean, I feel if you're 70, 60 or older, and there's a lot of if you're quarantining and everybody in your house is negative, there's no big reason to take it. But if you're a healthcare worker or you're commuting or you have exposure, I don't think it's a huge downside of taking Pepcid. I would take probably 40 twice a day. So.
All right, Tony, you're unmuted. So if you want to ask your question, go ahead.
Hey, good afternoon. Can you hear me?
Yep.
Yes.
Very good. Correct me if I'm wrong. Perhaps I heard this incorrectly. Maybe I didn't. But Dr. Ortiz, you mentioned something a few minutes ago that really caught my attention. You mentioned something about if a patient has symptoms, perhaps through the SPECT scan and the NOVA, perhaps showing decreased blood flow in the brain. Maybe they have an MRI that showed a recent stroke, or maybe they're having symptoms of TIAs. That would be an emergency situation, an urgent matter where you would need to take care of that right away, perhaps to save that patient's life. But now with the COVID-19 epidemic, that would be something that, and I believe that's what you alluded to, we would have to be kind of hold back on. How do we reconcile that with the patient and tell them, your life's at stake and we need to do this now, but because of COVID, we have to wait? I mean, how do we reconcile that with the patient?
The answer is that today we don't need to wait. As I said before, maybe 3 weeks ago, we were at the peak and there was no capacity in the hospital. We didn't have ventilators to do surgery in the hospital. But today, that is not the case. Today, that person would, yes, be a candidate for surgery and would undergo surgery this week if needed. So the final advice in this topic is that yes, we are all at risk of potentially contacting COVID. However, the risk is very, very, very small, and the risk of it becoming something serious to our health and becoming like a lethal disease is extremely small, smaller than the risk of having a major stroke from MoyaMoya in someone that undergoes a workup that suggests that they're, yes, at risk of having a major stroke. So it is, if that person fits the criteria for having surgery, they should undergo surgery now.
Jay, there's a question about indirect versus direct bypass. You want to take that one?
Sure.
Can you discuss the decision to go into recommendations for indirect versus direct bypass surgeries?
Sure. So a lot of that decision happens to be institution dependent and expertise dependent, and there's a lot of legacy associated historically with the type of surgery that's offered. I look at it from more of a necessity, medical necessity standpoint. And certainly if a patient is having acute crescendo-like symptoms, I'm more inclined to offer a direct bypass, which for everyone else out there that doesn't know what that means, it means we're directly using a blood vessel to provide blood flow to an area of the brain that doesn't have sufficient blood flow. So we are sewing in a donor vessel into a recipient vessel in order to immediately provide additional blood flow. And so I believe that the patients with more acute symptoms of hypoxic brain symptoms and who have reduced blood flow really benefit more from a direct bypass. Now, indirect bypass means that we are typically laying down vascularized pericranial elements such as the dura or some of the tissue within the scalp, and laying that onto the surface of the brain and allowing angiogenesis to take place. And this process can take weeks to months to have additional blood flow to that hypoxic brain. And so while I think it's a good procedure and it helps many patients with MoyaMoya-like symptoms, you don't get the same immediate improved blood flow as you do with a direct bypass. However, I have to say that it's important that the cerebrovascular center that's treating the patient do what they're comfortable with. Because if they're not comfortable doing direct bypasses, then they ought to do the indirect or refer to a center such as ours that is very comfortable with doing direct. So there's a fair amount of institutional legacy in terms of what's actually done.
I think it's this is a hot topic, honestly, partly because I think it's unfortunately healthcare is there's a financial incentive for people who are physicians. And I told Dean earlier, it took me about 10 years of really working hard to develop a skill set in bypass. And I made it a major focus of my life for a long time, and felt that I couldn't safely recommend this to people until I had done everything I could to make myself the best I can be. I put that time in. I know Jason's put that time in as surgeons. If you don't do that, or you don't choose to do that, you just want to treat patients, you can treat people with indirect grafts. And there's good data on indirect grafts in many situations that they work. The trouble is you don't know when they're not going to work. And it's a little bit of a I think, cavalier to offer people that operation only if you can't do both. And particularly if you haven't put the time in and put the effort in to do both. And this is a very difficult operation to master. I'm still learning. In every case, I learned something. Certainly with children, the indirect grafting is more common because the vessels are so much smaller. And so being a successful bypass surgeon on children is harder. I've done children as young as 4 with direct grafting, but in general, under 8 years old or so, until their heads are adult size, it's fine to do indirect grafting in kids. Also respect the fact that kids who present with this have classic Moya. And the other question is about diagnostics. We have a whole variety of different diseases that we're probably calling MoyaMoya disease. We think this is a phenotype. It's the way something looks. We're not genetic testing everybody or giving you a blood test and saying, oh, you have MoyaMoya disease. No, we're looking at an angiogram primarily, and that's just a phenotype. This is what it looks like. And it may be a whole constellation of different diseases. Some are this real true genetic MoyaMoya disease. Others are more of an acquired type. And so in kids, it's almost exclusively the genetic true Moya, or they've been radiated, or they have some other neurofibromatosis or some of these other factors that increase the likelihood. But if it's a child, I think indirect grafting, especially if they're small, is indicated. My personal bias, and I'm definitely biased, you absolutely have to be crazy to not put the right graft in. Because once you do it, if it doesn't work, you can't go back. You can't go back and open up again if the indirect graft doesn't work, or the indirect graft isn't enough. And what I will defer to my angiographic partners here, we do both. We put direct graft in and an indirect graft. And they can talk about sometimes the graft, the indirect, after, we have a very high patency rate in the high 90s of the direct grafts. And often you see the direct graft work right away. And then later on, a year later, we study all our patients at a year. And why don't you guys talk about what you've seen for these things when I'm done? But I think that in general, if you're an adult with MoyaMoya disease and you're symptomatic, you don't want to wait 3 months for it to work, number one. And if you have an ischemic variant or you have a type of Moya that's not the typical highly angiogenic Moya, I think indirect grafting is a cop-out on the part of the surgeons for not having the skills and the team to do it properly. And I'll leave it up to Yafell and Rafa. You know, I basically do angiography, not nearly as well as these guys do, but I do not do angiography on my own cases. Jason and I both, we're going to let the guys who are specialists with catheters, number one, they're better than we are with catheters. Number two, you don't want somebody looking at the graphs and looking at the bypasses who did them, because they're biased. I want somebody who's looking for a problem that can help me solve my own mistakes and point out, you know, oh, this maybe doesn't look so good. Because if I'm looking at my own angiograms, I'm going to be, oh, it looks great. You know, it's you don't want to put yourself in that position. And so I will never do an angiogram unless forced on my own bypass graft. And I'll let Yafell and Rafa talk about what they've seen as far as indirect and direct grafting.
I would agree with that, David. I think that in a lot of these adult patients that we see are in fact decompensated. You know, they are needing that blood flow into an area of the brain. And to that end, clearly a direct bypass would be the clear answer, I think, because these patients are already decompensated. They really need that blood flow going into that part of the brain. So I think I totally agree with that. And in terms of the diagnostics and putting it together with one question from one of the persons here in talking about how it could be misdiagnosed, I think it's going back to the fact that unfortunately many times the MoyaMoya type phenomena that we see mostly in adult patients in the US, you know, in many cases it can be overlooked. Sometimes, you know, the imaging findings are subtle, sometimes are not super clear. And unfortunately, if you get a scan in a place where people are not very used to interpret these studies, you may be, your diagnosis of MoyaMoya type phenomena may be overlooked. So going back to what we have said, the advantages of being in a center where you have a complete multidisciplinary way to approach MoyaMoya, from the diagnostic neuroradiologist to the neurointerventional person to the neurosurgeon who's very subspecialized in MoyaMoya. I think that's what you need for these cases, because many times, you know, they're not clear. They don't come with a label saying I'm MoyaMoya, unfortunately.
Yeah, to the point of this diagnosis, MoyaMoya is a spectrum, and and there's a process in which the narrowing of the arteries is progressive. So someone might have the first symptoms of a mini stroke with mild narrowing of an artery in just one side. And but when we follow that person 3 months later, 6 months later, 1 year later, you see that the artery keeps getting narrower and narrower and narrower, and then involving the other side as well in many cases. So I do understand why sometimes that can be missed, but that's the importance of experience here. The other part of that, if someone sees narrowing, and I've seen this mistake being made of putting a stent inside the artery, just like you would do for someone with atherosclerotic disease or hardening of the arteries. Number one, you're not going to fix the problem, and number two, you might make it worse, and you might have a complete blockage in a previously narrow artery. And the angiography, we're all different. All humans look different outside, so we all look different inside. And it's very difficult to determine ahead of time who's going to be the person that will have a more robust direct bypass 6, 12, 18 months after the bypass, or who's going to have a more robust indirect bypass. Everybody's different. The brains and our arteries adapt in different ways. We have seen people in which the direct bypass remains very robust and grows over time, and you don't see any indirect bypass even though it was planted. Number two, we have seen the complete opposite. We have seen an indirect bypass that recanalizes the entire hemisphere, one side of the brain, while the direct bypass shrinks and even disappears. You don't even see it. It goes away completely. Thrombosis, because there's no need. An artery is open if it is needed. And a bypass will stay open if there was a need for that bypass. And that's why the workup is so critical ahead of time. Because if you put a bypass, a perfect surgery, David or Jason might spend 4, 6, 8 hours doing beautiful surgery, connecting 2-millimeter arteries to one to the other. And if there was no need for that bypass, meaning if the brain had enough blood flow and collateral circulation from somewhere else, that bypass will not work, will disappear. So when some arteries grow, if you do an indirect bypass, if an indirect bypass grows, the direct bypass might shrink or completely go away because you don't need it, because the other arteries grow. So it is, and that's fascinating for us as doctors and geographers and neurosurgeons to observe how everybody's different and to learn with each case. And that's why the more we do, the better we get at it, because we have seen it before. So it's the practice. But yeah, we definitely love taking care of people that we can make a big impact. And MoyaMoya is definitely one of those conditions that are, I know they're rare. Numbers people talk of 1 in 300,000 people having MoyaMoya. However, that one person can suffer devastating injury if it's not addressed properly and in time. So we do love to take care of these people and have an impact. Preventing stroke, and when you have an impact, you don't have just an impact to that individual, but to their family members, to their co-workers, to their friends. It's a lifelong experience for them and for all of us as well.
I mean, I think that, going to just to finish up with the questions, you got to be with the team. The team is key, and we're not going to make a wrong diagnosis, because Moya is a spectrum of different things. The question is, are you having ischemic symptoms? Are you having stroke-like symptoms? And does your brain need more blood flow? Moya be damned. The way people make misdiagnoses, it's a congenital problem. It's a funny-looking artery. Somebody has a headache, and they call it Moya disease. It's not. By the same token, there are people that have classic Moya that don't get picked up because they don't get worked up properly. So you have both ends of the spectrum. And we obviously have seen all that stuff. And it's rare, so you have to go to a place as a great team that attracts lots of different kinds of problems. We conference every single case, with our group chat, and now in the post-COVID era, we're using all these new technologies to remotely work on these things together. And what we're learning, and that butterfly behind me is representative of the way we're approaching the post-COVID era, where we're using all the things that we learned, like Zoom conferencing or Microsoft Teams or mobility. So we're communicating with patients in unique ways. We're making videos for them. We're making basically FaceTiming people. If their patients are in the hospital and their loved ones aren't there, as horrible as it sounds, in some ways it might be better, because sometimes the patients need their family members when they get home. And if they exhaust themselves and sit at the bedside for 3 days, and then when the patient goes home and they nearly need to be taken care of for a few days at home, just a little TLC, they'll be more well rested. We can make it easier on you by sending you videos of your loved one and FaceTiming you and giving you that feedback. That's what the butterfly is about. It's about expanding our technology and making good diagnoses, having groups of people conferencing, looking at stuff together, getting other opinions. And then your misdiagnosis becomes less common. And if we do treat you, we're going to use those same technologies to communicate with the patients at home. The truth is, there's no such thing as elective surgery if you're symptomatic. When you do, it's a different question. If you're symptomatic, you need treatment. And if you have blood flow deficit and you're worked up and you need treatment, whether you do it or not, you may take an elective strategy and say, well, wait, when after my wedding, I want to do it after that. But in general, if you have symptoms and you don't have enough blood flow to your brain, whatever it's called, you probably need more blood flow, and then leave it up to a good team to help you through that. I can't tell you how much I appreciate this opportunity. The only other question is what dose of Pepcid I recommend. The answer is I don't know. The recommended dose of Pepcid is 20 twice a day. I would probably, if I was prophylaxing, probably take between 40 and 80. You do have to check your creatinine. So you talk to your internist, because Pepcid at a higher dose can increase the chance of renal insufficiency. So again, this is a hot off the presses, and the data's coming out. If I got a cough and a fever, I would take 80 twice a day. If my mom did, I'd probably start her off about 40 and then maybe increase to 80 depending on symptoms. We're treating people with 120 3 times a day in the hospital as part of the clinical trial, IV, huge doses, mega doses, but then these people are sicker and we're following them very closely. But in any case, that's all I have to say. I want to thank my partners. Every one of them is just an outstanding doctor, has worked very hard to be the best we can be. We've put an enormous amount of energy and an enormous amount of empathy and compassion into treating our patients. And particularly, as Rafa said, this is an incredibly important thing we like to do. Saving a stroke is worth it. And especially tend to be young women in general. And so we feel, my father had a stroke, I know what it's like to live with someone who's had a stroke. And I think we all are very driven to do the right thing. Also, the worst thing you can do as a physician is give someone a stroke. So we take that very seriously. And so our threshold to treat is based on that precept. We want to avoid them and not cause them. And because living with someone who's suffered is I'll take one patient that has a stroke that I'm involved with is worse than, it doesn't make up for the 10 you help. And so we have to be very circumspect and only treat the people that absolutely need it. I don't know if you guys have anything you want to add. We're closing in on our 5 o'clock spot. Any final comments? Dean?
I just want to thank you all real quick before you finish up, but thank you for inviting me today to ask some questions and to share with the MoyaMoya community on World MoyaMoya Day your insights on MoyaMoya and how your team operates. It's really impressive to hear how you guys collaborate. I know I've seen it firsthand in the past, and it amazes me every time I see it. Thank you.
Yeah, I'm just typing off there's one other question here to one of the participants. And, one thing I must say, we would never look at someone else and say what I would have done or could have done. It's up to the patient and the family to choose a team that they trust. For us to comment on how other people, I tell my team, never look out of the boat. We don't really care what other centers are doing this way or that way. We do, that we learn from other people, but we have a way of treating patients, and we're going to stick to it. And telling us, other people that they should have done this, that doesn't get anybody anywhere. Everyone suffers when we do that. So we're remarkably sensitive to the fact that I think, in general, people are trying to do the right thing. And so if you do have any other questions, feel free to reach out to us through the web or through our Twitter feed or our Instagram. And we're happy to see people in telehealth. All that information is available online. We welcome any and all questions going forward. And we really appreciate this opportunity to educate the MoyaMoya community on a special day like this. And I think we have to thank Dean for starting this evidently. And I hope your daughter does well forever. And thank you again for giving this unique opportunity.
Oh, thank you all. Appreciate it.
Thank you.
So much.
Thank you.
And for the person that asked a question, if they want a second opinion, obviously they can come to us and we can look at the films and take it from there.
Great.
Excellent.
All right.
All right.
Great
Thank
discussion.
you.